Rahim. Can we start now?
Yes, Dr. Fatin.
Thank you. So today we're going to revise on the fluid and electrolytes. I have modified some of the content to better suit for your clinical practice. So hopefully it shall be a beneficial sharing this morning. So hopefully by the end of the session today, you will be able to describe the body fluid compartments, the composition of the body, and what are the percentages and the rough estimate of the volume of fluid in each of the body compartment. And we also need to know what are the main electrolytes in each of the body fluid compartments, including the cations and also the anions, and to compare the osmolarity and also tonicity, especially with the fluid, the intravenous fluid that you're going to use in treatment. We also need to be able to differentiate between sodium balance and water balance, as well as the sodium balance and the sodium concentration. What are the differences? And finally, to describe what are the disturbances in the body fluid balance, what are the consequences, and how does your body try to correct the disturbances in the body fluid balance changes. All right. So roughly, you will need about 30 to 40 milliliter of water per body mass per day. So usually, if in a standard 70 kg man, you will need about roughly 2 to 3 liter of water per day. There are some other criteria or ways of calculating the daily fluid requirement by using the body surface area and also the metabolic rate. But probably the weight, using the weight is probably the most popular and the most used method in the clinical practices. However, you need to be careful because this estimate may not be accurate in certain circumstances, including in those who are obese, in the elderly patient, as well in those who are having cancer. Because of the difference, for example, in those with cancer, they have a different metabolic rate, and in the obese patient, they may not have the lean mass may not be similar to the other non-obese patients, and also in elderly, they may have a lower metabolic rate as well. Other factors that you need to consider when calculating the daily fluid requirement include some other pathological conditions, for example, in the patients with trauma or acute peritonitis, or in those with altered metabolic requirements. Right. So roughly, in a normal healthy person, the total intake will be equal to the total output of the water itself. Usually, your total intake will be roughly, you will have a total water intake about 2,300 ml, in which most of them will come from your oral fluid intake. And the rest will come from the carbohydrate metabolism, from your Krebs cycle, where you metabolize the glucose to form the carbon dioxide and also water. So a small portion will come from that process itself, from the metabolism. Most of the water loss will actually goes into your urine, okay, about 1,400. So that is more than half of your total fluid loss comes from your urine. You also have some portion which is about 700 that of water loss, which are considered insensible, meaning that we don't really get to measure it. So that is usually from the skin as well as from your respiratory processes from the lungs. And then a small portion comes from the sweat and the feces. what about if you are exercising heavily? So when you exercise heavily, then you will have a lot of fluid loss from the sweat itself, which will actually causes the fluid loss from the urine to be reduced. So because your main fluid loss will be from the sweat, the water loss from the urine will be reduced. However, despite the lesser urine, the total output of the water is still high, which is about 6,600 if your sweat is about 5 liters. And this will actually causes you to drink more of your water here, so that your total intake will actually matches your total output. And of course, in a clinical setting, you also need to consider some other causes of pathological water loss. For example, in those patients with vomiting, diarrhea, bleeding, as well as in burn patients. So we know that our body is at least 60% is made up of water. But where does this water distributed? So you need to know that in the body, this 60% of water, 2/3 of them, which is about 40%, is actually in the cells itself. So there are more water in the cells compared to outside the cells, which is the extracellular space or the extracellular fluid. And outside the cells, this water can be distributed in two compartments, which we call the interstitial fluid or the internal environment. This is the fluid that bathes the cells, that surrounds the cells. And about 20% of this extracellular fluid is actually the one that is in the blood, which make up the plasma. You need to know that female has less body fluid compared to male. So in terms of the percentage, it is about 55% versus 60%. The elderly also has lower percentage of body fluid, which is about 50 to 55%, but the infants have more body fluid, which is about 70 to 80%. Therefore, you can say that the distribution of the total body water is actually it is inversely proportionate to age, because the elderly the older you are, the less body water you have compared to the young. There's also a small proportion of fluid in the extracellular space, which we term it as transcellular fluid. So transcellular fluid is the extracellular fluid which is not interstitial fluid and not plasma. For example, your saliva, your sweat, your urine, your CSF, what else? Your amniotic fluid, okay? So we don't really call this fluid as either interstitial fluid or plasma. And if you look at some books, they will make another category, which is the lymph, which that under the extracellular fluid as well. However, both transcellular fluid and the lymph, the volume is usually noted as negligible, meaning that it's too little to quantify, right? Apart from the amount of water that is different according to age, the distribution of the ECF and ICF may also vary with age. For example, in an adult, 40% of the water, 2/3 of the water in the body is contained within the intracellular fluid. But in an infant, there is equal distribution between the fluid in the ECF and also the ICF. So what are the main electrolytes in the body fluid compartment? So I'm sure you are all very familiar with this. So in the extracellular fluid, which is the plasma and the interstitial fluid, the main cation, so cation refers to the positively charged ions, is the sodium. So sodium makes up the main cation in the extracellular fluid in both compartments. Whereas for the anions, which are the negatively charged ions, The main anions in the extracellular fluid are the bicarbonate and the chloride. Conversely, in the intracellular fluid, the main cation will be the potassium, whereas the main anion will be the phosphate and the protein and also the plasma proteins. So this is just showing you the approximate concentration or amount of the cations and anions across these two main body compartments. So as I mentioned before, in the extracellular fluid, you will have more of the sodium and also the chloride and bicarbonate, whereas in the intracellular fluid, you have more of the potassium as well as the phosphate and the protein. Despite the differences in the distribution of the electrolytes or the anions, you need to note that the osmolarity of these two body fluid compartments are the same. Okay, we're going to look about osmolarity more afterwards. I think you learned this earlier with Dr. Roslina. Why do we have more sodium in the extracellular fluid and less potassium and more potassium in the cells? This is mainly generated by this sodium potassium ATPase, sometimes called the sodium potassium pump. So this is the main pump or protein carrier which actually works, but in which it moves 3 sodium out and 2 potassium into the cells. And this transport itself is an active transport because it utilizes energy in the form of ATP. Why does it need to be an active transport? Because this pump is working against the concentration gradient, meaning that we know that the sodium is high on the outside and low in the inside. So by naturally, the sodium will tend to move into the cells, right? But then this pump is actually tries to maintain this distribution by pumping out the sodium out into the cells across the concentration gradient. And this is why it needs energy. So in the extracellular fluid, we have the interstitial fluid and the plasma. So the plasma and the interstitial fluid in general, they have very similar composition because the interstitial fluid is actually the ultrafiltrate of plasma, meaning that it is the filtrate of the plasma, but without some of the components which are the protein, because these proteins, they are large, they cannot readily cross the plasma membrane or the endothelial wall of the capillaries itself. So what are the differences between the plasma and the interstitial fluid? As I mentioned before, the first one is you have the proteins in the plasma compartments. You have all these plasma protein found in the blood vessel, but you won't in a physiological circumstance, you should not be able to find any of this protein in the interstitial fluid. And this itself has some consequences to the distribution of the other electrolytes. Because these plasma proteins, they are usually negatively charged. Okay, because they are negatively charged, our body always tries to maintain the electroneutrality of a compartment, because these plasma proteins are negatively charged. The plasma then will have a slightly lower concentration of the anions and a slightly higher concentration of the small cations to electroneutralize this plasma protein. And this process is part of what we call as the Gibbs-Donnan equilibrium. You don't need to know further more about this. You just need to know that the differences between the plasma and interstitial fluid is mainly contributed by the plasma protein itself. which then affect the distribution of some of the anions and also the cations. Why do we need to maintain the difference in the electrolytes composition in the intracellular fluid and the extracellular fluid? Well, there are several reasons which are related to the physiological functions of the body itself. For example, you need to have a concentration gradient of the potassium to determine the resting membrane potential of the excitable tissue, for example, the nerve and also the muscles. The difference in the sodium concentration also determines the upstroke of the action potential in these nerve and muscles as well. You need also to have a different concentration of calcium inside and outside of the muscle cells because it may influence the excitation and contraction coupling in these myocytes. And finally, the higher sodium in the extracellular fluid may also help with some other functions, for example, the absorption of essential nutrients, for example, the glucose, which is coupled to the sodium itself when it needs to be transported from the ECF into the ICF. So this is what we call as the secondary active transport. Now, I mentioned to you earlier, although there are different distribution of the electrolytes in the extracellular fluid and the intracellular fluid, both of the compartments have roughly the same osmolarity. So osmolarity is actually a measure of the solute concentration itself. Okay. First, before we look at the osmolarity, let's look at the molarity itself, which is also a measure of solute concentration. So molarity is when you measure the concentration of a solute in mole per liter. So it's quite simple. Okay, osmolarity is a bit different. It is the measure of the solute concentration, but it takes into account the osmotically active particles per unit volume of fluid. For example, how do we calculate this osmolarity? We need to know the molarity of the solution and also the dissociation factor. What is the dissociation factor? It is the dissociation of the solute itself in water. For example, if you have a sodium chloride solution, sodium chloride itself in the water, it will dissociate into the sodium ion and the chloride ion. So the dissociation factor will be 2, right? So if I have 1 mole per liter of sodium chloride, so the molarity of that solution will be 1 mole per liter, but the osmolarity will be 2 mole per liter. Okay, so 1 mole of sodium ion, 1 mole of chloride ion. But if these solutes does not dissociate, for example, you have glucose or urea, so the dissociation factor remains 1. So the osmolarity will be equal to the molarity of the solution itself. This one you need to remember, the osmolarity of the body fluid is approximately 290 plus minus 5. Some books they will use 207, 287, some will use 300, but it's roughly around this number. And it is not osmo, but it is milliosmo, yeah, for the body fluid osmolarity. Okay, comes the next important point for osmolarity is that osmolarity, while it measures the osmotically active particles, it does not differentiate between the penetrating or the non-penetrating solutes. What do I mean by penetrating and non-penetrating? Okay, this is usually referring to the solute that can cross the semi-permeable membrane freely and readily. Okay, for example, most of the electrolytes or most of the ions, because of the charge, they cannot simply cross the semi-permeable membrane. So we call them as the non-penetrating. Okay. Some other molecules like glucose, they are they are large and they cannot cross the semi-permeable membrane as well. The classic penetrating solute that we usually refer to is urea. Okay, so urea is small, it is non-charged, it is uncharged, so it can readily cross the semi-permeable membrane. Okay. Osmolarity, apart from calculating the molarity and times it with the dissociating factor, there's a device that we can use to measure the osmolarity, which we call as the osmometer. Okay, osmolality. Okay, the difference is only the letter L here. It's similar to osmolarity. It's just that it uses the ratio is over the unit mass of the fluid. So it's usually for milliosmol per kg. And in the body, because the main fluid is actually water, in which 1 kg of water is usually equal to 1 liter of water, there's not much difference. So it doesn't really matter to either we use osmolarity or osmolality. But most of the times we will use osmolarity. Okay, what about tonicity? Okay, tonicity, it also measures the solute concentration as well. However, it only consider the concentration of the non-penetrating solutes, which are the solutes that cannot cross the cell membrane or the semi-permeable membrane freely. Tonicity, we don't really give a unit because it is more like a behavioral term. It is a comparative term. It means that we compare one solution to the other, and because of that, there is no unit given to tonicity. Okay, what are the impact, or what are the importance of knowing the tonicity of a solution compared to other? Is that you need to know that because the non-penetrating solutes, they cannot cross the cell membrane or the semi-permeable membrane. What happens is that the water will then move across the membrane until the concentration or the osmolarity on the two sides is equal. Okay, so it actually affects the net water movement, meaning that to say if you have 2 beakers of water, even if there is similar tonicity between these 2 water, there will still be water movement from A to B and B to A. What we meant here by net water movement is that we need to look at what way will be more of the water moving into. Okay, right. Now let's do some exercises. Okay. Is isoosmotic solution always isotonic? The answer is no. Okay, so let's look at some solution here. This is some made up solution. Okay, if you have 150 millimole per liter of NaCl, so this one is, what kind of concentration are we talking about here? What is the term for millimole per liter?
Molarity.
Molarity. Okay, so the osmolarity will be 300 because yes, because of the dissociation factor. Okay, so when you compare the osmolarity to the plasma, okay, so in this case, let's take the plasma as 300 in terms of the osmolarity. So it will be the same, right? 300 to 300, so it is isoosmotic. Now, when we look about, when we to determine what is its tonicity compared to plasma, we need to only take into factor which solute? The non-penetrating solute, right? So in this case, both of the sodium and the chloride. Okay. So because it is also both the osmolarity of the the concentration of the non-penetrating solutes is also 300, then the tonicity is also the same. So we call it as isotonic. Okay, how about glucose? Okay, because glucose is glucose penetrating or non-penetrating?
Non-penetrating.
Very good. So osmolarity, because it's not dissociating, osmolarity will remain as 300. So it is still isoosmotic, and because it is the non-penetrating concentration is also 300, it is also isotonic. Now let's look on urea. Okay, urea of about 150, osmolarity is 150. So 150 compared to plasma 300, it is isoosmotic. Very good. And what is the concentration of the non-penetrating solute in this solution? There's none, right? Because urea is penetrating, so there's none. So let's assume this is a pure just water and urea. So there's no other solute. So there's the tonicity will be hypotonic as well, because there's none of the non-penetrating solute. Even if you increase the urea to 300, and now it becomes isoosmotic, but because this one is penetrating solute, the tonicity is still hypotonic. Okay. Now let's mix some urea and some of the sodium chloride now. Okay. So you have 300 osmolarity here. So sodium chloride here is also 300. So 300 and 300 is about 600. Compared to 300 osmolarity of the plasma, it is hyperosmotic. But in terms of the tonicity, it is considered as isotonic because of yes, because the non-penetrating solutes still have the concentration of 300. So that is similar to plasma. So it is isotonic. Now let's look at some of the solution that you will be often using in the clinical setting. Okay, before that, this is a very general rule. Isoosmotic solution is not always isotonic. Hyperosmotic solution is not always hypertonic, but hypoosmotic solution is always hypotonic. Okay. These are some of the solutions, some of the crystalloids that you are familiar with. I took the osmolarity reading from this website here. Okay. So for this case, let's assume that anything between 250 to 375 is considered isoosmotic. So if you use the normal saline, the most popular one, normal saline, it is considered as isoosmotic, and the tonicity compared to plasma is also isotonic. But if you use lower half normal saline, the osmolarity is much lower as well. The osmolarity, so it is hypoosmotic, and when you compare to the plasma, it is also considered as hypotonic. If you use a much concentrated sodium chloride, the osmolarity is 1,003, for example, 3%. The osmolarity is about 1,000. It is hyperosmotic, and when you compare to the plasma, about 300, it is still hypertonic. Okay. Sodium chloride is quite easy. Now let's look at the dextrose or the glucose. Okay. So which one do you usually use in surgery?
5%.
5%. Okay, so let's look at the 5%. So 5% is quite commonly used because the osmolarity is about 253. So as I mentioned before, 250 to 375, let's consider that as isoosmotic. Okay. But then when you compare to the plasma, it is actually quite hypotonic because the dextrose itself is, dextrose, it is
Non-penetrating.
It is. Oh, sorry. Yeah, it is non-penetrating, right? But then why does it become hypotonic? Sorry, let me check again. So yeah, sodium chloride is the same. Glucose, it is isoosmotic, it is isotonic. Because it is non-penetrating. Oh, yes. This is right? Isoosmotic, it is 5%. It is isoosmotic, but then it is hypotonic. It's similar to the other dextrose as well, meaning that when you use dextrose, doesn't matter what is the percentage, it can become hypoosmotic, isoosmotic, or hyperosmotic, but usually it's more hypotonic compared to the plasma. But so this one is just dextrose in water. But if you use dextrose or glucose in sodium chloride, then depending on the sodium chloride concentration, the tonicity will then changes according to the solution that you the sodium chloride solution itself. Okay, in the Ranger solution, you have more than just sodium and chloride. Okay, and the osmolarity is about 273. It is of course isoosmotic, and it is isotonic because most of them are non-penetrating solutes. Right. When we talk about the water balance, we usually refer it, when we talk about fluid balance, we usually refer it to the extracellular space. Okay, so in the extracellular space, there are two things you need to consider, which is the osmolarity as well as the volume. Okay, you need to know that the major determinant of the extracellular fluid osmolarity is mainly the sodium ion concentration. Why? Because the sodium ion concentration makes up the most of the the sodium ion has the highest concentration among the other electrolytes in the ECF. Of course, you have the other anions as well, but the sodium itself on its own is has the highest amount or highest concentration or contributes to the highest concentration in the ECF itself. What is the major determinant of the extracellular fluid volume? Okay, so for the ECF volume, the major determinant is actually the sodium balance, which also known as the total body sodium. So you need to be able to differentiate between the sodium concentration and the sodium balance. So the sodium concentration, it determines the ECF osmolarity, but the sodium balance or the total body sodium, it determines the ECF volume. Why? Because apart from having the greatest effect on the ECF osmolarity, this sodium also it exerts the highest osmotic pressure gradient to attract the water. Because the sodium it cannot readily cross the semi-permeable membrane, so it needs the ion channel, right? Because of that, when there is a difference in the sodium concentration or difference in the ECF osmolarity in the two compartments, instead of the sodium going out from that compartment, the water will actually move in to equilibrate the osmolarity between the two compartments. So what is the osmotic pressure? It is the pressure difference in the solute concentration across a semi-permeable membrane that actually drives the osmotic water flow. So another reason why sodium is the main determinant of the so sodium balance is a major determinant of ECF volume, right? And I mentioned before, sodium concentration is the main determinant of the ECF osmolarity. So let's look at how the sodium concentration affect the ECF osmolarity. What happens is that we have this osmoreceptor in our hypothalamus, which is very sensitive to the osmolarity of the ECF, mainly the plasma lah. Okay, so what happens is that when the ECF osmolarity increases, it will then actually stimulates the pituitary to release a hormone known as the antidiuretic hormone, and then this will causes water conservation, meaning that there is increased water reabsorption in the kidney mainly, which actually normalize the ECF osmolarity. Okay, So that is how the sodium concentration actually affects the ECF osmolarity. And of course, when there is water conservation, there will also be changes in the ECF volume. However, you need to know that the ECF volume, it does not really, the changes in the ECF volume, it is not primarily caused by ECF osmolarity, but rather by the total body sodium itself. Let's look at a situation in which you drink the water. Okay, so when you drink the water, what happens to your total body sodium? So your sodium balance, it actually does not change, meaning that if you have 1 mole of salt, 1 mole of sodium in your body, even if you drink more water, you still have 1 mole of salt in your body. It does not change the absolute amount of the sodium itself. However, the concentration will change because there is an increase in the fluid volume. So the sodium concentration and the ECF osmolarity will decrease. Okay. In this situation, the water balance itself will increase. This is what we call as the positive water balance. Okay. When we talk about the ECF osmolarity changes, you need to know that usually the changes in the ECF osmolarity is caused by the disturbances in the water balance and not in the sodium balance. So you rarely have the situation where your sodium is your sodium amount in the body changes, for example, increases or decreases, unless unless in very specific situation like you're eating very salty food or you are on very hyper osmotic sodium chloride infusion. But most of the time, the osmolarity changes due to disturbances in the water balance itself. So this is just a summary on how the sodium the sodium concentration or the sodium concentration changes, not the sodium concentration, sorry. How does the body react to the changes in the osmolarity of the plasma? So say if you have an increase in osmolarity, for example, if you are on taking a very salty crisp or salty food, you actually stimulate, there's increase in osmolarity, which actually stimulates the osmoreceptor, which then stimulates the pituitary to release this vasopressin, or known also as the antidiuretic hormone. Okay. So what happens is that it will increase the water reabsorption in the kidney and there will be reduced urine output. And eventually, your plasma volume will increase. At the same time, your plasma osmolarity will also decrease to normal. Okay. At the same time, when the osmoreceptor is stimulated, it also stimulates your thirst, meaning that you will increase, you will naturally want to take more water, okay? Which actually leads to increase in plasma volume and also reduce in plasma osmolarity. So this ADH, apart from just affecting the plasma osmolarity, it also affects the plasma volume as well. Okay, what happens is that when your plasma volume is increased, it can actually increases it, another stimulant of the osmoreceptor itself is that when you have very low not the osmoreceptor, if you have a volume depletion, so your ECF volume decreases and your arterial blood pressure decreases, what happens is that if this changes is large, okay, only in large changes in plasma volume or arterial pressure, then it can also stimulate the neurons in the hypothalamus. In the hypothalamus, which can actually lead to release of the vasopressin as well. However, this is only when you have very severe volume depletion. Okay. This is another diagram or another flow chart of showing the processes from the changes in the plasma osmolarity leading to the correction of the plasma osmolarity, which involves the ADH as well as the thirst. Right. How about the sodium balance? Okay. When we talk about the sodium concentration or the osmoregulation, we talk about ADH. But when we talk about sodium balance, it's usually the aldosterone. The hormone is usually the aldosterone. Okay. So let's look what happens if your sodium load is low in the body. Your blood pressure will be low. Okay. The hyponatremia itself can actually straight away stimulate the aldosterone. So aldosterone is a hormone that is released from the adrenal gland, which can then actually stimulates the renal to increase the sodium reabsorption in the renal itself. At the same time, the low sodium in the body will actually causes low sodium in the renal filtrate, which actually can causes this reflex known as the tubuloglomerular reflex, to reduce the GFR and to reduce the sodium filtered. Okay, and both of this mechanism can actually help to correct the changes in the sodium load in the body itself. Right, so this one I mentioned to you, when we talk about volume status, we usually refer it to the ECF volume. You need to know, although we say that the ECF volume, although we usually talk about the ECF volume, this ECF itself can causes changes in the ICF volume and osmolarity. Because why? Our body will naturally will try to not adapt. The water itself will then try to move between the ECF and ICF, so that the osmolarity will reaches equilibrium between these two compartments. So any changes to the ECF will cause changes in the ICF volume as well as the osmolarity. What are the routes to reach the ECF compartment? So there are the oral or also the intravenous route. So let's look at the disturbances of the body fluid. Okay, when we talk about the disturbances of the body fluid, it can be either contraction or expansion. Contraction means that you talk about the volume reduce, contraction, volume increase, expansion. And then you talk about the osmolarity, if it is hypoosmotic, isoosmotic, or hyperosmotic. So these are some of the examples of when you have hypoosmotic contraction, hypoosmotic expansion, isoosmotic contraction or isoosmotic expansion, hyperosmotic contraction, and hyperosmotic expansion. Right. This previous diagram here, it actually will help you to understand the changes. Okay, so let's have a look here. For example, if you have diarrhea, so diarrhea, you lose a lot of water as well as electrolytes. So most probably you lose an isoosmotic solution to your diarrhea fluid, right? And the loss will always start in the ECF. Okay, it's always start in the CF. So this is what we call as the isoosmotic contraction. So the volume will reduce, but the osmolarity remains the same. How about in water deprivations, meaning that you don't drink enough water? Okay, you don't drink enough water. So what happened in the ECF? Okay, in the ECF, when you don't drink enough water, the osmolarity will increase. Okay, when the osmolarity will increase, when you don't drink enough water, first we call it as hyperosmotic contraction. So you have you have less water in the ECF, and the osmolarity will also increase. Okay, what happens is that the water in the ICF will then try to move into the ECF. Okay, until the equilibrium, the osmolarity of the ICF reaches the same as the ECF. Okay, until it reaches the same. So in the ICF, the osmolarity will also increase, and there will be also volume contraction. Okay. In adrenal insufficiency, in which you have you lose both water and also sodium, but we call it as the hypoosmotic contraction. Okay, so what happens here is that the osmolarity of the ECF is reduced. Okay, when the osmolarity of the ECF is reduced, this water in the ECF, although the ECF is already contracted, but because the ECF is reduced, the water in ECF will then tend to move into the ICF, okay, until the osmolarity of ICF is equal to the ECF. Therefore, you will have the reduced osmolarity in the ICF as well. This one is for volume expansion. So volume expansion, usually you look at the ECF again, okay? So if you give normal saline, you give both water and also enough salt. So there will be expansion of the ECF, but there is no changes to the osmolarity. Therefore, there will be no changes in the ICF. Okay. When you take a lot of sodium chloride, for example, you take salty food, okay, there will be increase in the osmolarity, of the ECF. What happens is that the water in the ICF will tend to move into the ECF until it reaches the equilibrium in terms of the osmolarity. Therefore, you will see that in the ECF there will be volume expansion. In the syndrome of inappropriate ADH, meaning that you have too much ADH, there will be hypotonic expansion, meaning that your volume will be increased, but your osmolarity will be decreased. Why does the volume increase? It's because the water from the ICF will tend to move into the ECF to equilibrate between the osmolarity between the two compartments, right? Okay. So some of the rules when you talk about the body fluid disturbances. First one is that the changes to the ECF volume can be with or without changes to the osmolarity. Okay, so you can always have isoosmotic contraction or isoosmotic expansion, meaning that you lose almost the same ratio of the water and the salt, or you gain almost the same ratio of the water and salt. When I say ratio, it means that the fluid has almost the same osmolarity to your body fluid, to your plasma. Okay, the rule number 2 is that the changes in ECF volume may or may not affect the ICF volume. As I mentioned before, the changes in the ICF volume really depends if there is any changes to the ECF osmolarity. Okay, so if the osmolarity in the ECF does not change, there will be no changes in the net water movement and also in the volume and osmolarity of the intracellular fluid. But in other types of disturbances, there will be changes in the ECF osmolarity, which actually changes the net movement of water, which will then changes the volume and also the osmolarity of the intracellular fluid. Okay, so although when you're doing when you assess the hydration status of the patients, usually that will almost always referring to the extracellular fluid compartment, which is usually the plasma, right? You just need to know that any changes that you make to the plasma, to the extracellular fluid, will eventually will affect the intracellular fluid. And there's no way that you can reach the intracellular fluid by bypassing the extracellular fluid. There's no way. So any changes you want to introduce, you need to go to the ECF. Right. So let's look at some clinical situation. Okay, so after donating blood, so your ECF volume will increase or decrease? Decrease. Yes, because you are losing some blood. Okay, and the ECF osmolarity will be the same, because you don't really only donate water, the fluid, the water part of your blood. You also donate the electrolytes as well. So osmolarity will be the same. Will there be any changes to your ICF volume and osmolarity? No. Okay. Right. So how does your body restore your ECF or your blood volume after you donate your blood? Yeah, so the vasopressin through this mechanism here. This, not this one, sorry. This one here. So losing ECF volume reduce your arterial blood pressure, stimulates some of the hypothalamic neurons, but not the osmoreceptor. Okay, not the osmoreceptor, just the hypothalamic neurons, which can then increase the vasopressin as well as stimulates the thirst. Right. So this situation will also be similar in other scenarios. For example, when you have diarrhea, when you vomit, or you have a burn patient, because they will lose both water and also the electrolytes. Now, so after exercising, let's talk about exercise. You sweat profusely. So I know I mentioned before, sweat is not considered as either interstitial fluid or plasma, but it is still part of your extracellular fluid. Okay, it's part of your, it's called the transcellular fluid. Okay, so what happens to your ECF volume? Reduce. Okay, how about the osmolarity? Increase. It's actually increase. ECF osmolarity actually increase because your sweat is actually hypotonic compared to your plasma. Okay, although your sweat is very salty, I'm sure some of you have tasted your sweat every now and then. Although it's very salty, it is actually hypotonic. So you probably can imagine your blood is much more saltier than your sweat, right? So your sweat is actually hypotonic. So in this case, your ECF osmolarity will actually increase. Okay, so that will also have, you can derive the changes to the ICF volume and osmolarity on your own. Okay, so what happens is that how does your body restore your ECF volume? So because this one mainly affect the osmolarity, so it will go through the osmolarity route, the osmoreceptor, the ADH, rather than the atrial pressure pathway. So this one mainly through the osmoreceptor, the osmoregulation. Okay. After eating salty crackers, okay, this one is a bit tricky. So when you eat salty crackers, if you don't drink water, then nothing changes. It doesn't change your ECF volume, right? Yes. But it will increase the ECF osmolarity, right? So what happens is that when your ECF is increased in the osmolarity, water will tend to move from the ICF into the ECF, right? So your ECF will eventually increase. So this one is called as hypertonic expansion. Sorry, hypertonic expansion. Okay. How does your body restore? Because the main changes is in the osmolarity. So how does your body restore your ECF osmolarity? That one is mainly through the osmoreceptor and the osmoregulation pathway. Right. After drinking too much plain water, so water without no other electrolytes, ECF volume will increase. ECF osmolarity decrease. Okay, so it will eventually causes, or it will change or doesn't change the change the ICF. So this one, how does your body restore your ECF osmolarity? Of course, it will inhibit the ADH. It will inhibit the ADH secretion because it decreases in osmolarity. Finally, if you drink too much isotonic sport drink, okay, so ECF volume will increase, ECF osmolarity will remain the same, right? Because it's isotonic, yeah. How about the ICF volume? If it doesn't change the osmolarity of the ECF, there will be no change to the ICF volume and osmolarity. All right, okay. There's some other, if I'm teaching the undergrads, I will continue with the styling forces of the capillary, you know, the capillary as well as the lymph. But if you need some notes on that, I can give to you as well. The important things about the styling forces is that you need to be able to differentiate between hydrostatic pressure as well as the oncotic pressure, hydrostatic and oncotic. I think it's quite you're quite familiar lah with that concept. I can give you that notes as well if you wish to have. Any question? Anything in the chat? Let me see. Nothing. Who do I contact to give the notes? Is it Dr. Haris, is it?
Dr. Haris.
Yeah. All right. So I'll be in contact with Dr. Haris. Thank you, everyone. Apologize if I do not meet your expectation. However, thank you for your kind attention. All the best with your upcoming examination. Thank you. Assalamualaikum warahmatullahi wabarakatuh.